It's a pleasure to be here tonight on this webinar talking about OPTALYSE and implementing it into your practice. Thank you for attending, and let's get started. Here are some relevant disclosures. Now, I know a lot of you are out there or actively practicing treating pulmonary embolus, and many of you may just be starting, but I want to get a sense of the audience and the attendees on how you would treat submassive pulmonary embolus patients. So this is our first polling question, and we'll kick it off here. Let's first start by asking how would you treat submassive P? Would you use anticoagulation alone? Would you use systemic fibrinolytic therapy? Would you use EKOS and Seattle 2 protocol, which many of us are familiar with? Or would you use EKOS in one of the lower duration, lower lytic dosing protocol arms? Or would you do an other type of treatment? So we'll give you some time here and let you respond. So, so we have an interesting breakdown. So about 63% of the attendees who are here tonight would use EKOS and a Seattle 2 protocol of 1 milligram per hour for a total of 24 milligrams of TPA. And 20% would opt for lower duration, lower lytic dosing, which would be the OPTALYSE protocol, and about 17% would use anticoagulation alone. So I think that's 0% would use systemic lytic therapy, which I think is very appropriate. So what we're talking about tonight is the submassive P population. It makes up about 40% of the P population. This is not a benign disease process. About 21% mortality occurs at the 3-month time period. Now, the question that often comes up in the submassive patient population are, why are these patients at risk? Well, there's some key factors that contribute to the hemodynamic stability or instability of these patients, and this is a nice schematic of what happens in acute submassive pulmonary embolus with an increase in RV afterload that occurs with the inciting event. And what you see here as you come along this spiraling in the right side of the circle is you start to develop RV ischemia, and then after RV ischemia, a cascade of events ultimately results in a drop in systemic blood pressure, coronary perfusion, low cardiac output, and now you have once a stable patient who now becomes hemodynamically unstable. And this is the RV tipping point, if you will, in these patients, that once their RV begins to fail, this can be a very difficult patient to recover, and you ultimately have to use some measures such as ECMO or IV lysis to try and salvage these patients, which can be very challenging. So why would we treat submassive P patients aggressively? Well, there's various studies that report on the presence of RV dysfunction as a predictor of poor clinical outcomes, namely mortality, adverse events both in the hospital and in follow-up, and increased recurrence of venous thromboembolic events in patients who have RV dysfunction. Now, these studies have been around for several years, some much longer, but they are very consistent in what they show. And the RV-LV ratio, both derived from CT scan and echo, has been shown to be an independent predictor of mortality in the setting of submassive pulmonary embolus. And not only is this an independent indicator of mortality, but as the RV ratio increases, so does the mortality risk. There's also association in patients who have not had resolution of RV dysfunction at the time of discharge, have 8 times more likelihood of developing recurrent venous thromboembolic events than the cohort who did have RV recovery at the time of discharge. So these are really important factors to consider when we treat this patient population, who by definition are hemodynamically stable, but clearly RV-LV ratio could be a very useful risk stratification measure, as well as an independent prognostic indicator as well. Now, how do we treat these patients? Well, certainly intravenous thrombolytic therapy does work. Unfortunately, the price to pay is in increased bleeding and increased rates of intracranial hemorrhage. The goals of endovascular therapy are really twofold. The first is to, as you can see here, to rapidly reduce pulmonary hypertension, reduce the RV strain, reverse the RV dysfunction, really facilitate the RV recovery. And just as importantly, certainly, is that endovascular therapy does allow us to achieve these reversals of RV dysfunction, but offering a method of treatment which has lower bleeding and much lower rates of intracranial hemorrhage. Now, if we look at thrombolytic dosing treatment strategies, historically, systemic thrombolysis, as you know, requires typically 100 milligrams of TPA. Traditional catheter-directed thrombolysis has historically required upwards of at least 48 milligrams of TPA, depending on the duration of treatment. And when we started to see Seattle 2 published and presented and adopted and implemented, we began to see a substantially lower dose of total TPA, and that was 24 milligrams. And that became a standard approach for many of us when we started treating pulmonary embolus patients with the Seattle 2 protocol. Now we have OPTALYSE, and now we are starting to see even a further reduction in total lytic dose, which certainly for operators and especially for patients, I think is a welcome addition to our treatment options. Now, this is the device we're talking about. This is the EKOSonic Endovascular System, or the EKOS catheter. It's a 5.4 French system, high frequency, low power system that involves use of an infusion catheter. And then inside that is an ultrasonic core wire that delivers the ultrasonic therapy. There's many treatment zones. Typically the 12 and 18 centimeter treatment zones are the more commonly used for pulmonary embolus treatment. Now this is not a standard thrombolytic catheter. This is, as mentioned, has a acoustic pulse thrombolysis mechanism of action, whereas the ultrasound will start to break down and separate the fibrin strands within the clot, and then also results in acoustic streaming of the lytic drug into the clot. So additional mechanism of action that can help facilitate this system and treating acute thrombus. The EKOS system is FDA approved. As we'll see, it's the only FDA approved device to treat pulmonary embolus. It's also approved to treat in the peripheral vasculature as well. There is CE mark approval in Europe for very similar indications, both in the peripheral vasculature and for treatment of pulmonary embolus. Now, it's difficult to get into discussion of OPTALYSE and what that means unless we talk about two very important studies in the emergence of EKOS therapy for our patients. ULTIMA just was a randomized study of EKOS treatment versus standard heparin anticoagulation. This was a European study, and what this showed was that in patients who were randomized to EKOS and heparin, they had a significantly reduced or improvement in their RV function, both in hospital and at 90 days follow-up. The patients who were randomized to just heparin alone in the 90-day follow-up still had a portion that were having severe and moderate RV dysfunction compared to almost complete recovery in the EKOS therapy arm. Now, in the United States, there was a trial, as many of us are familiar with, the Seattle 2 trial. And this was important for several reasons. One, it was a nice sample and diverse group of operators. There were interventional cardiologists, interventional radiologists, vascular surgeons, cardiothoracic surgeons. So it really demonstrated that with a standard protocol, many different specialties and operators can adopt this approach and treat patients safely and with good efficacy. Seattle 2 was looking at the reduction in RV-LV ratio at the 48-hour CT scan and a safety endpoint, which was measured within 72 hours of therapy. Seattle 2, as many of you are aware of, showed a significant decrease in the RV-LV ratio over the 48 hours, and this was about a 25% decrease in the RV-LV ratio. Now, after ULTIMA and Seattle 2, that really set the foundation for the FDA to provide approval and clearance of this device to treat pulmonary embolus. There was a standard 24 milligram dosing, which again allowed a lot of the operators around to really develop a standard regimen and protocol for their patients. And obviously, with the reduction in RV-LV ratio, the reversal of RV dysfunction, and very low risk of intracranial hemorrhage. This was really a welcome to our treatment options for our patient. However, there remained questions, and two of the questions that continued to come up even after Seattle 2 was implemented was, can you reduce the risk of bleeding without compromising efficacy by reducing the fibrinolytic dose? The second question was, can you improve procedural efficiency and potentially reduce cost by reducing fibrinolytic infusion time? So the EKOS Corporation really was presented with a fork in the road with the decision making. They had FDA clearance for the only device to treat pulmonary embolus. They could have rested on their laurels and be satisfied with that, or they could have continued to innovate and push the envelope. Now, fortunately for us and our patients, they decided to continue to innovate and push the envelope, and we had OPTALYSE trial. Now, the rationale for OPTALYSE, as you can see here, there was some very clear pharmacologic and physiologic reasons why we thought that a lower lytic dose and a lower duration may work. Systemic thrombolytic therapy, as many of you are aware, is a 2-hour infusion with TPA. It's even less than that with TNK, as was shown in the PYTHOS trial, just 5 to 10 seconds of TNK bolus. And in MOPPET, it was again a short 2-hour infusion of 50 milligrams. Now, the pharmacology of TPA has a very short initial half-life of less than 5 minutes. Terminal half-life is just over an hour. And Dr. Goldhaber nicely showed that fibrinogen levels remain low at 24 hours, even after 2-hour TPA infusions. Now, the physics of fluid dynamics, as demonstrated by Poiseuille's law, shows that flow is proportional to the radius of the vessel to the 4th power. So what does this mean? It means that small improvement in vessel diameter can potentially lead to a substantial improvement in blood flow. So not all the clot needs to be removed, but if you remove enough, you can substantially improve blood flow within the pulmonary vasculature. Now, all these made sense, but I tell you what was more interesting is that as we began Seattle 2, and a lot of the investigators and operators began reporting back that after about 2 hours of treatment, we began to see rapid clinical improvement in these patients. And this became a more consistent finding that we were seeing in these patients. And this, in conjunction with these physiologic and pharmacologic rationale, really set the stage to allow us to jump into a very novel trial. And that was OPTALYSE PE, and this was really to evaluate the duration and dose of EKOS therapy. It had very similar efficacy and safety measures that were shown in Seattle 2. There was about 17 centers in the country and about 100 patients. These were 4 cohorts, so there was no other trial that has ever had a study design like this for pulmonary embolus therapy. These 4 cohorts had randomized about 28 patients in each cohort. Cohort 1 was just 2-hour infusion, and that was 2 hours, and with a bilateral case was 2 milligram per catheter would give you a total of only 8 milligrams of TPA. Cohort 2 was a 4-hour infusion, and again, if you look at a bilateral P case, this was 1 milligram per hour per each catheter, and that was a total of 8 milligrams of TPA. Cohort 3 and 4 were our 6-hour infusions. Cohort 3 was 6 hours at 1 milligram per hour for a total of 12 milligrams of TPA. And cohort 4 was again a 6-hour infusion with 2 milligrams per catheter for a total of 24 milligrams of TPA. Now, there was primary efficacy, primary safety, and secondary endpoints. The efficacy endpoint was a change in RV-LV ratio, again, very similar by design to Seattle 2. The primary safety endpoint was, again, similar to Seattle 2 in major bleeding within 72 hours. And then the secondary endpoint was a modified Miller score, which is a CT-derived score on clot burden and also clot resolution, which gave us some quantitative information on clot removal with these different cohorts. Now, OPTALYSE has been completed. The manuscript has been submitted, but this data and information has already been out there for quite some time. It's been presented at 3 major society meetings, and these are meetings that represent different specialties from pulmonary critical care to cardiology and to interventional radiology. These are the results. Each cohort, 1, 2, 3, and 4, all showed statistically significant decrease in RV-LV ratio. Regardless of what cohort the patients were in, they all showed significant reduction, and these were very low p-values as shown. This was very similar with the 25% reduction as was shown in Seattle 2. Cohort 1, again, was 2-hour infusion. Cohort 2 was just a 4-hour infusion. Cohort 3 and cohort 4 were a 6-hour infusion arms. All showed significant decrease in the RV-LV ratio. Results of these EKOS trials are really, I think, practice changing. You have OPTALYSE, Ultima, and Seattle 2. You have over 280 patients. You have TPA dosing from 48 milligrams all the way down to 4 milligrams. And if you look at the right-hand column, the reduction in the RV-LV ratio is really the same. So we're really starting to see convincing and compelling data on lower lytic dosing, even than what we saw in Seattle 2, lower lytic dosing, lower duration with similar efficacy. There have been very low bleeding rates within OPTALYSE. There was 3% bleeding rate. One patient had anemia secondary to pretreatment facial trauma after a syncopal episode. The second patient developed bleeding from a splenic pseudoaneurysm. This was treated. And there was 1 intracranial hemorrhage in an old elderly patient with a history of thrombocytopenia and labile hypertension. In a timely presentation, Dr. Tapson and his colleagues compiled the EKOS trial data, which consisted of data from Ultima, Seattle 2, and OPTALYSE PE, and showed that within the EKOS therapy data that's been completed, there's only a 4% major bleeding rate event and a very low intracranial hemorrhage rate of less than 1%. So this overcoming of the hurdle of intracranial hemorrhage is really important. If we look at, again, all EKOS studies and compare it to historical rates of intracranial hemorrhage, we see that EKOS therapy has a very similar rate of less than 1% of intracranial hemorrhage as compared to just anticoagulation alone. Systemic IV fibrinolysis consistently has been shown both in longer registries such as ICOPER and more contemporary data such as PYTHOS to have a 2 to 3% rate of intracranial hemorrhage. So in summary, we have OPTALYSE PE, which has 2, 4, and 6-hour cohorts. We have significant reduction in the RV-LV ratio, and when compared to our previous standard, which was Seattle 2, we have similar efficacy, better safety in half the time and half the dose. Now, what does this allow us to do for our patients? Well, it really gives us greater flexibility. Shorter duration times can give greater flexibility in treatment option, and we certainly have seen in our practice the ability to take these patients on a much lower lytic dose and duration and treat them in the morning and allow us to transfer them out of the ICU the same day. Clearly, lower lytic doses correlate with better safety profiles for these kinds of procedures, and there is potential cost savings for hospitals with less ICU stay and lower length of stay for adoption of OPTALYSE protocol. Now, let's pause here for a second. I think this is a good spot to ask a second poll question. So now that we've presented the OPTALYSE data and you're familiar with some of the different cohorts, which protocol would you choose for your submassive P patient? Would it be the 2-hour protocol or the 4-hour or the 6-hour? Or would you stick with Seattle 2 protocol, 12 hours? Or would none of these be compelling to use? We have a really an interesting split and in the webinar that was done before this one, we actually had a very similar split, is that many of you feel comfortable treating and using OPTALYSE protocol, whether it's a 2-hour, 37% chose 2-hour, 29% chose 4-hour, and 36% chose 6 hours. 8% still remained in the Seattle 2 protocol. So I think that's a great polling response there. So let's move on. And what I do want to share with you, which I also think is just as interesting, is EKOS did a survey among operators, and these were operators from all different specialties, and there's about 60 operators that were asked the question, based on the results of OPTALYSE, do you plan on treating PE with EKOS therapy more? And an overwhelming response, about 73%, said they would. I think this is certainly what we're finding in our own practice, where we are, is that there are patients now that we, with OPTALYSE protocols, would consider EKOS therapy for, where with Seattle 2 we may not have felt as comfortable. These typically are the patients who are elderly or are in some sort of post-operative state. So certainly I think that's consistent with what we're seeing in our own practice. Now, this survey, which I think also just as interesting, these are not operators but referrers. So this question was asked to multi-specialty physicians who refer patients for EKOS therapy, and the question was that based on the results of OPTALYSE, will you refer more PE patients for EKOS therapy? And about 80% of the referring providers said that they would, and that was based primarily on OPTALYSE protocol offering lower lytic dose, shorter duration, and better safety profile. And we have certainly seen this in our own practice. We have really an excellent collaborative relationship with our hospitalists and pulmonary critical care docs, and they have really attached to this OPTALYSE protocol, and we certainly have seen an increase in some patients and referrals since implementing these protocols.